to open up the second day of the symposium. You're welcome, sir.
Thank you so much. I will start by saying a very big good morning to everyone. Just like the moderator rightly mentioned my name, I'm representing the Director of Public Health, unavoidably absent. And I wish to recognize the National Coordinator for putting up this event. And also, let me start by recognizing dear commissioners from various states that are here present this morning. It's not easy to grab a commissioner to remain in Abuja for 2 good days now. I'm sure some of you have even come in before the day of the event. So you have spent about 3 days now. Our dear academicians from various institutions that have been selected to be part of this event, I still spot out some of them that have been working together within the past days when I was on a HIV member. I will not say the word staff, let me use the word member of the HIV program. Our dear members from the UN that are here present, our dear partners, various stakeholders that are here, media, and my dear colleagues from the ministries. I want to start by saying that the caliber of people I met this morning has given us an impression that in no distance time, we are going to work toward elimination. We will advance from control to elimination of HIV in Nigeria. A few years ago, when I had an opportunity to anchor HIV program, we were worried, we were struggling then. Even when we had some challenges, our mind was, how do we move from this stage to the second stage? We were still at the level of, how do we tackle the menace of this disease? I think then we were still on the single dose or single therapy antiretroviral drugs. Toward my exit from HIV program, the combinative therapy, the DTG, now came into existence. And we're saying, good, we are making progress in Nigeria. The number of dates have started reducing, and we have been able to achieve remarkable results. Just like we are advancing in PMCT and pediatric coverage today, there's still a gap. If you look at it in the past, the knowledge was, once you are spotted that you are HIV patients, it becomes a death sentence. Today, I live along with them, I go along with them, I'm still consulting with them, and they are free, happy people. But the alarming rate among the youth is still issues to be worried about. And we still have a lot, just like you rightly mentioned, that at the subnational, especially at the community level, we need to still tackle and work towards ensuring that we have 100% coverage. The challenge will still be there. And it is something that we all know about it. Today, I will implore everybody not to look at the program at the national level again, because we have achieved a lot, but we should look at how we step it down. So to my dear commissioners and researchers that are here, you have a lot of tasks to do at the subnational level. At the state level, especially at the LGA and communities. I'm from a typical community, and I know the impact of HIV touching high in my community. And that is why I'm challenging this forum this morning. That you will brainstorm, you will discuss, but we need to look at how we can sustain it, work toward controlling it at the community level, and ensure not only sustaining, the community becomes the owner of the program, and by so doing, the burden will be reduced at the national level, and the state will be able to tackle it effectively. I'll leave you with a story. I was opportune to visit a primary health center. And along the line, we were to obtain some data on a particular program that we went. And we have 3 pregnant women that was attending antenatal clinic then. Now, one came in because he was having malaria. The other one came in because he was HIV positive. And the other one came in with another illness entirely. And they were debating within themselves. I'm always frequent at this clinic. And always frequent at this clinic. Now, all of them were at the first trimester of pregnancy. The malaria woman complained that she has been going into the clinic more and more. And the other ones also complained. But the one with HIV did not complain much. And all of them were debating among themselves. If I had opportunity, you are looking more healthier than me. You're an HIV patient. And none of them did not know any of them did not know their status. Only the anti-nurse, let me use a common word. Those health workers that were there in the hospital were the one that knows their illness. And while the 3 friends were discussing, one of them said, if I had my way, I would check your own sickness and you check my own. Now, this comes from the woman that was having malaria. It therefore means that those that were suffering HIV was well taken care of and it was well treated. What am I trying to say here? Is that we need to ensure that we work toward securing no death as far as HIV program is concerned in Nigeria. That was a plus. But at the end, when both of them disclosed their problem, the other people were shocked and said, you are HIV positive. How do you manage? I think the other one was hypertension in pregnancy. How do you manage? And the answer was, nothing than for me to be consistent with my drugs. Drugs accessibility is still a challenge in some of the health facilities, even though we have it, but there's still scarcity in some facilities. And especially those hard-to-reach area, because I've been once affected since I'm coming from that riverine area. We need to tackle HIV in that hard-to-reach area. Many are still yearning for survival, and we need to do something. So I want to charge this forum this morning that it is not over until it's over. We have a lot of tasks and we have a lot of things to do. Let me also appreciate our partners who have been joining, working hard to ensure that we achieve this success. But as a country, we have a lot to do in terms of mobilizing our resources, not depending on the donor any longer. And if we mobilize resources within the country and work towards sustaining this program within the country, it will come a time that we can tell the donor and our partners, please rest. We can manage ourselves and remain fit. So I want to charge this forum this morning that we have a lot to do, and by God's grace, if we join hands together and collaborate effectively, we'll be able to achieve success. Thank you so much.
Thank you very much, Dr. Akpan. Please, a round of applause for him again for that heartwarming speech. Very well spoken, sir. Thank you very much. Okay, we would respectfully again like to ask some of the commissioners to please move forward. If you would like to occupy the front seat. Yes, please put your hands together for them as they make their way to the front seat. Thank you, Ma. Thank you, sir. Yes. And something special is happening today. In fact, multiple things are happening today. A lot of special things. This is a special date, the 23rd of July. We want to recognize someone remarkable. It's his special day. This is going to be coming as a surprise to him. Is the Permanent Secretary, Ondo State Ministry, in the person of Dr. Adeniro Ayotunde Ikwomola. Today is his birthday. Happy birthday to you, sir. Happy birthday. Happy birthday. Please let's celebrate him. Would like to sing a happy birthday song to you. Happy birthday to you. Happy birthday to you. We can rise. Happy birthday, happy birthday. Happy birthday to you. Hip, 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 hooray! Hip, 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 hooray! Hip, 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 hooray! Yes, we rejoice with them that rejoice. Happy birthday, sir. May the good Lord continually keep you, bless you, protect you. Amen. All right. So now we will be going on to the next sessions. But before we do that, I know that we've taken a lot of pictures today. Please do not forget, post on your social media handle. A lot of things are happening in Nigeria, out of Africa. But the reason why people do not know is because we do not broadcast it well enough. So please, can we broadcast? This is an amazing symposium that has been convened. It's remarkable. There's a milestone that is happening here in Africa for the advancement of PMTCT and, just prevention of HIV/AIDS and even the total eradication and elimination. And it's happening on our soil by us. So please don't forget to use the hashtag NASCP 2025 or NASCP FMoH. I wouldn't forget that. NASCP FMoH. Please, hashtag. Okay, thank you very much. We'll be going into the technical presentations, and it will be coordinated like it was yesterday. Yesterday, we had the moderator. I'll read up just a very brief profile of his, and when he comes up, he would read up the profile of the presenters that we'll be having for this first session. Now, the first presenter is the person of Dr. Umar Bello, and the entire session will be talking about, yes, please. The entire session will be talking about enhancing pediatric ART coverage. Please, you can give him more and more warm applause as he comes up. You're welcome, Dr. Bello. Dr. Bello is a seasoned public health, no, you can take the stage. I'm right here. He's a seasoned public health physician with over 15 years experience. He's a fellow of West African College of Physicians. He has a master's in public health with special interest in epidemiology and another master's in public health and nutrition. He is the state AIDS and STI program of Katsina State, a deputy director, public health, State Ministry of Health, Katsina, and he also serves as a visiting lecturer at Umar Musa Yaradua University in Katsina. He has obtained a lot of certificates in leadership and program management inside and outside of the country. The most recent one was Cologne Business School in Germany. He has a lot of interest in research and academics, and he has published over 10 papers in high-impact journal. Ladies and gentlemen, once again, I present to you Dr. Umar Bello.
Thank you, MC, for the introduction. The Director of Port Health permit me to stand on the already established protocol. Well, I will use this opportunity to once again congratulate NASCP for organizing this platform to discuss HIV in Nigeria. It's quite a commendable effort. Well, yesterday we had a lot of discussions. We had about 3 technical sessions where we discussed issues related to advancing PMTC and pediatric treatment coverage for Nigeria. Yesterday, throughout the discussions after the morning session, we had a lot of discussion about prevention of mother-to-child transmission, where we invited expertise. We had a lot of presentations and discussion. This morning, we're going to continue with that discussion, where we're going to have a lot of discussion around enhancing pediatric coverage in HIV. Well, to do this, I have 3 experts that I'm going to invite here on the stage. And we have about 1 hour, 45 minutes to do that. And in the course of the presentation, we will have session for question and answers, and also after that will come after the presentation. The first person that will come on stage is Dr. Ehime E. Please, can you come forward? He's a dedicated and experienced medical doctor with nearly a decade of progressive experience in public health. He currently serves as a pediatric and adolescent HIV focal person at the National AIDS Viral Hepatitis and STI Control Program under the Federal Ministry of Health and Social Welfare, Nigeria. In this capacity, Dr. Ehime has played a pivotal role in strengthening the national response for children and adolescents living with HIV, giving health quality for vulnerable population. Can we please appreciate him again? The next person that will also lead us in another conversation today is Akamu Alani Suleiman. He's a professor of hematology and consultant at Lagos University Teaching Hospital. So can you come forward, please? Where's Professor? Yeah, let's appreciate him. With expertise in immunohematology and hemo-oncology and HIV medicine. He chairs Nigerian National Task Team on ART and HIV drug resistance Technical Working Group. At LUT, he leads Harvard PEPFAR-supported services overseeing over 22,000 HIV clients and advanced diagnostic. He played a key role in NBNUB Global Health. Currently, he's serving as a mentor in Forgery Consortium, Harvard, Boston, and Northwest University, and University of Mexico, NHBNU. A global health training program developed to promote mentored research among junior faculties, low-income and middle-income countries. He also leads molecular biology laboratory. Can we please appreciate Prof again? Yeah, the next person is Dr. Peter N. He's a deputy director and head of treatment care support, NASCP. Can you please come forward, Dr. Peter? Yeah. An intelligent and committed and highly motivated public health professional with vast experience in patient-centered care, HIV, AIDS, and TB program management, human resource for health and research. He's also dedicated toward contributing to achievements of healthy and self-sufficient nation. He has over 15 years working experience in public health program, strategic information and data management, as well as program management. He has been involved in many national surveys on HIV, as well as development of national guidelines and policy documents. He's a team player, an excellent communicator, and good collaborator who never shy away from difficult challenges. He's also dedicated toward contributing to achievements of healthy and self-sufficient nation. He's a resilient and ready to help out with additional role that will contribute to achieving set targets and objectives of organization. Please, can we appreciate him again? Well, like I said this morning, we have 1 hour 45 minutes to discuss enhancing pediatric ART coverage. And to start with, the time allotted for each presentation is going to be 15 minutes. But for Dr. Ehime and Prof, I'm giving them 30 minutes each, while Dr. Peter will take 15 minutes, and then we use 30 minutes for question and answers. I will first start with Dr. Ehime because he has 2 presentations. That's why I'm giving him 30 minutes. I will call on Dr. Ehime to come and make presentation on Global Alliance to End AIDS in Children by 2030, progress and next steps, and also family index testing, a key strategy for early HIV case identification. Please, can we appreciate Dr. Ehime? Yes, I think.
So good morning, everyone. Global Alliance to End Pediatric AIDS come 2030. We started this conversation in August 2022, and luckily for us as a country, we joined the alliance, and we were part of the phase 1 country to the Alliance to End Pediatric AIDS. Now, the Alliance is structured. Next slide, please. Okay. Next. Thank you. The Alliance is structured in such a way that it has a vision. And the vision is for us to end pediatric. And we are operating with 4 pillars, from pillar 1 to pillar 4. Pillar 1 is concerned with pediatrics and adolescents living with HIV. How do we test them? How do we link them to care? Pillar 2 and 3 is talking about PMTCT. But for pillar 2, we are looking at how do we close gaps, the treatment gaps in PMTCT. And pillar 3 is looking at how do we ensure that we prevent new infections in pregnant and breastfeeding women. Pillar 4 is unique in the sense that it's looking at how do we address rights, gender equity, and social and other structural barriers that hinder access to care. Next. So our attempt to go through pillar by pillar, telling us how far we've gone as a country. Each of the pillars have so many activities. So we'll be taking it through the priority interventions, the key activities implemented in each of the interventions, and then the results we've achieved to date, and the impact of reduced funding for interventions. Because of time, we'll just limit ourselves to these 3 main priorities. The first is the FIT that I'll be talking about shortly. So permit me to skip that. We'll move to the second priority area. We are looking at how do we ensure that we upgrade our data capturing tools. And in this case, is the ENDAS. And we've been able to do that. If you go to the ENDAS, you discover that we've been able to, you can actually validate data for children and adolescents there. The third priority we're looking at is how do we ensure that we reach out to the hard-to-reach areas with POCs. And we've been able to do that. As we speak, in country, we have about 85 MPMA machines, and we've been able to upgrade our Gene Expert machines, about 144 of them, to ensure that we push the needle a little bit when it comes to AID. Kindly recall, in December 2023, the EID percentage for the country was at 18%. But because of this intervention, we've moved it now to about 55% at the end of last year. Can we put our hands together for that? Next slide. So on pillar 2, we are looking at PMTCT, like I said. A lot have been said about it yesterday. How do we push the needle a little bit? And we've done that. For the service delivery point, we've moved it from about 6,000 service delivery points to about 40,000. And a lot has to go into this training, building capacity, and all that. The second priority area in pillar 2 is looking at our test kits. We've been having a little bit of challenge there, but because of the way we're going with the implementation of the plan and with the directives from the director, national coordinator of NASCP, we've been able to see how we can procure so many of these test kits to distribute. Yes, we still have some challenges with that, but we're trying to see how we can overcome that. The next priority for this pillar is training of healthcare workers on the ENDAS. We've been doing that across board. Thanks to the SI team for doing that. Next slide. On pillar 3, we are looking at just 2 priorities there. How do we scale up retesting amongst pregnant and breastfeeding women? And then, how do we scale up PrEP for this subpopulation? A lot has been going on here, but as a country, our focus was more on pillar 2 because of the gaps that we have in pillar 2. Kindly recall yesterday when the director was making his presentation, he said that the government of Nigeria declared an emergency for PMTCT. So all attention was geared towards achieving the aims that we have for pillar 2. So pillar 3, a lot of work is still going on, but our priority for the country is pillar 2. Next slide. So on pillar 4, we were trying to see how can we overcome the out-of-pocket expenditures by PLHIV. And based on the directives of the national coordinator for now, as a country, we have to focus on how do we ensure that we increase coverage, how do we ensure that PLHIV are enrolled into the health insurance scheme, and then the third point is very key. My boss will be coming on to speak on that. That's service integration. And a lot has been done in country, and we've been able to push a little bit, but there's a lot that needs to be done. The community have been involved all along. Next slide. Across the pillars, we ensure that we engage the communities and we are working closely with them to achieve our aims. Next slide. Because of time, I'll leave the most successful interventions across the pillars. Let me just focus on the least successful interventions. On pillar 1, we want to do more when it comes to retention. On pillar 2, we have to distribute these test kits to ensure that across all the service delivery points, test kits are available. On the third pillar, we want to do more on scaling up of PrEP. Of recent, there are a lot of conversations ongoing, and we're trying to push that. And the last, which is pillar 4, how do we enroll a lot of PLHIV into the health insurance scheme? Currently, we have about 4,000 PLHIV currently enrolled in the health insurance scheme, but we need to do more. So this is just telling us about what the country did. Next slide, please. When the funding squeeze came on board, the country came together. We tried to see how we can improve on our stock, distribution of the test kits, how we leverage on available resources, and a lot of facilities had to reduce their MMD to be given just a month and all that. The whole aim is to ensure that we're able to manage what we have in country. At this point, I would like to appreciate everyone you see here. Can we put our hands together for ourselves, please? Because this initiative cannot be done by NASCP alone. Like I said, we need all hands to be on deck to be able to do this. And most especially, I would like us to appreciate our academia especially. They've really done well. Professor Kamu is here. We have Professor Oladokun here with us. And we also have Professor Chiagbaji. They've been guiding and steering us towards the right direction. So thank you, everyone. Can I proceed? Okay. So this is the second presentation. And I would like to dwell more here because we were thinking. Next slide. Next slide. Next slide. Thank you. Next slide. Okay. I won't dwell more. You have talked about it. This is still stemming from the Global Alliance. Next slide. So our aim was to see how we can focus more on the first pillar. And in that pillar, like I said, we have a lot of activities there. But our aim was to focus on the first activity. Next slide, please. Which is line listing and testing of children that are less than 14 years of all PLHIV across the health facilities in Nigeria. Reason being that if we can get this right, we can be able to move our coverage in country. And so what did we do? We set out, we had a lot of consultations, physical consultations, virtual consultations, to ensure that we list all children of index clients across the country. We also determine the coverage and then see how those that have not been tested, how do we test them? So we set out and we said, let's look at women, the reproductive age from 15 years and above. But because of the directives from the national coordinator again, he advised that no, let's take it down to 10 years and above so that we can capture all the women that needs to be here. Because you agree with me that in the northern parts of this country, we have women less than 15, pregnant and giving birth. So we wanted to cover as many persons as possible. Next slide, please. Next slide. Next. Thank you. So this is the roadmap. We, like I said, have a lot of engagement with everyone here, physical and virtual, to see how can we test these children of PLHIV across board. Because for us, that was a low-hanging fruit. So what we did in NASCP was to develop a questionnaire which we imputed into the enders, and then we set out. We initially looked at the testing strategies we have in country. Next slide. And we discovered that we needed to explore, next slide, some of the testing strategies we have. As you can see, clearly displayed, we have a lot of testing strategies in country. Some of them are carried out at the facility level, a lot happening at the community level. But we are interested in the second bullet there, that's the family index testing. And we focused on the facility. These women coming to the facility. Next slide. How can we get all their children to be tested? When we started this conversation, next slide, we were assured by the implementing partners that this is taking place already. And so for us in NASCP, it's just to leverage on what is happening. Next slide. And so we got the NREC approval, and then we started enrolling PLHIV that are 10 years and above and their children into the ENDA. So we created an additional module for that. We did a lot of training, capacity building virtually. And currently, as at 30th of June this year, we have about 421,026 index clients that have been enrolled into the ENDAs. And then we are having from these index clients 144,891 children that are less than 15 years enrolled as well. So next slide. Apologies, this is a little bit tiny. I don't know if you can see from the back. So we just pulled this one out from the ENDAs this morning. So as we speak, you can see that all the states, we've given them the targets for all the states. And then these are the index clients that have been enlisted. So I don't know if you can see your states there. Let me just give Abia, for instance. We have about 28,286. That was the target given to Abia. They've been able to enlist 11,827 index. Out of this, we have 1,400 children. Okay? And out of these children, those that are less than 15, we're having about 2,921. If you follow this cascade down, you will discover that for a lot of states, it was actually accurate, but so many of them were having data inconsistencies. And so again, the director and national coordinator also gave a directive that it is better for us to go down to these states to see what is happening, to validate this data that we have showing on the ENDAs. And of course, we did that. We want to appreciate Global Fund and UNICEF for supporting the national program in going to all the states. We did that in batches, as you can see. Next slide. Yeah. So we did that in batches, as you can see, from February this year to April. We covered all the states. We went there. We went to facilities to see what was happening and see how we can actually validate this data. Next slide. And the validation process started. Next slide. So we'll just quickly run through this early analysis that we did after the validation. Next slide. So this slide is quite interesting. It's telling us about the validation team that went to all the states. However, although we visited all the states, the data that we analyze now is from 33 states. We're looking at the data from Zamfara, FCT, Delta, and Gombe State. We have them, but we're trying to clean them up so that we can infuse into the ENDAs and then do a complete analysis. However, from these states that we visited, we to assess 155 health facilities. And we went to look at the folders. We were able to assess 6,443 folders across these facilities. We visited an average of 5 facilities per state. And next slide. This is the results, ladies and gentlemen. We did the analysis in such a way that we were able to, we did it based on the geopolitical zones. So as you can see, northwest states, we have some parameters that we used in doing the validation. States like Jigawa, Kano, they were okay. The data was actually corresponding with what we're seeing. But we still have a little bit of discrepancies in states like Katsina, Kebbi, and Sokoto, in the northwestern states. Like I said, the analysis is ongoing, but we just had to pull this out to just show us what is happening across board. For the northeastern states, you can see Adamawa doing very well. Same with Borno and Taraba. But we still have some data inconsistencies with Bauchi and Gombe states. So moving on, next slide. For the north central states, we have Benue states having good validated data. But the other states still have issues in their data. In the southwestern states, you can see Ekiti is doing well. Ondo, Osun, and Oyo states, we were able to verify the data that we validated. And but Lagos and Ogun states, we still have a lot of work that needs to go in there. Next slide. For the southeastern states, doing very well, but we still saw a lot of data discrepancies across the states, except Abia and Anambra that at least perform a little bit above par. So the key here is that anywhere you see green, those states have 91 to 100. Anywhere you are seeing yellow, they have 80% to 89%. Anywhere you are seeing pink or red, it's less than 80%. We can't go below that because it's data validation. Take a look at the south states. Akwa Ibom, Cross River, but a lot of data issues across board. So what is this telling us? That from the analysis, we have over 50% of states that still have issues with their data. So what next are we going to do? That brings us to the next step. Do we now say, okay, let's see how we can go to those states and troubleshoot, and then see how we can quickly close the gaps? Do we now repeat this same process again and see how we can get it right? So we, in NASCP, will still rely on the guidance from the national coordinator on what to do concerning this. I believe we need to call a workshop, take a look at this, and then see how we can mobilize for more resources. Like I said, this is a low-hanging fruit strategy that we need to do. All PLHIV, we need to test all their children. And partners have been doing that. We are relying on them to do that. But this is just the results that we are seeing now. This is not the whole results. These are just the early analysis that we just did for this symposium. So thank you, everyone. I want to appreciate UNICEF and Global Fund for supporting us, and also CHAI for helping us with the analysis. So thank you, everyone.
Thank you, Dr. Ehime. Can we please appreciate him more? He managed to finish in 20 minutes. Thank you, Dr. Ehime, for keeping to time. I think let me just give you like a point of discussion when we come to question and answers. He mentioned 4 things that are least successful in terms of global alliance to end HIV among pediatrics age group in Nigeria. He talks about retention. He talks about availability of test kits. He talks about scaling up PrEP and enrollment on health insurance. We need to take note of these 4 key points, please, so that when it comes to discussion, we discuss extensively on them. Then his last presentation, he talks about troubleshooting in state with gaps. We've seen the states. He mentioned them. We really need to think, how can we now clean the data and see the actual problem in those states as related to index testing. Then revisiting states for revalidation of that information that was collected. Then resource mobilization for index testing, very important. We need to think about those things when we come to discussion time. The next person that I will call on is Prof, and he's going to take us through HIV drug resistant in pediatric patients. Can we please appreciate Prof?
Thank you. So, we'll be troubleshooting the issues of HIV drug resistance and focusing on the children. Let's first of all remind ourselves, what do we mean by HIV drug resistance? What we mean is that a particular drug or a combination of antiretroviral drugs are no longer able to prevent the virus from replicating. Then we say HIV drug resistance has occurred. But that resistance occurring is a natural phenomenon of the virus. Whether you bring the drug or you don't bring the drug, the virus will develop mutations. And some mutations will naturally be drug-resistant mutations. What makes the virus to be able to develop mutations is the very bad property of that virus they call HIV. You see, the virus, we refer to it as a quasi-species virus, in the sense that in an individual that is living with the virus, if you take one virus, it will be different from another, and they are all HIV. What makes that happen is the infidelity of HIV enzyme that is designed to cause the replication. It's called nucleoside reverse transcriptase enzyme. That enzyme does not obey the law that governs biological enzymes. That law is that an enzyme should identify its substrate and work only on its substrate, but not so the HIV nucleoside reverse transcriptase. It will look at adenine and will think it is guanosine. It will see cytidine and it will think it's thymidine. So when it's doing the replication, it regularly makes errors, and it's inborn property of the virus. That is what is causing quasi-species. And the rate of mutations has been calculated. For every 100,000 replicons, one is usually a mutant. When you now calculate that in a 24-hour period, up to 20 billion replicons will be made, and one out of every 100,000 of these 20 billion will be a mutant, you can see that in a 24-hour period, you can have up to 200,000 mutations, viruses that are different from one another. So the issue now is that all these mutations have different effect on the virus. Some mutations are actually good mutations in the sense that when it occurs, it makes the virus to become more susceptible to the drug. But it can also occur and make the virus less susceptible to the drug. In that case, we say resistance has developed. Mutation can occur and will make the virus to develop the capacity to infect macrophages more. And macrophages will move the virus into the brain. And therefore, you can see some patients developing neuropsychiatric symptoms. Mutations can develop and make the virus to be able to develop the capacity to fuse to cells, what you call syncytium-inducing viruses. And therefore, all the CD4 cells will fuse together rapidly, and within 2-3 months, that individual CD4 cell count will fall, and the individual will develop illness. Majority of mutations that occur actually have no effect whatsoever on the virus. We just call it polymorphic mutations. And there's nothing that's happened to the virus in terms of whether it's going to become more deleterious, have more severe effect on the individual or not. So mutations occur, resistance occur. However, we know that no mutation will occur if the virus is not replicating. So the faster the virus is replicating, the higher is the likelihood that mutations will occur. We have said that for everybody, for every person that has viral load, like 100,000, 300,000 viral load, viruses per copies per mil of plasma, in less than 0.1 day, mutations must occur. The lower the virus level, the viral level, the lesser is the likelihood, or the longer it will take for mutations to occur. In other words, our tool against preventing any mutations, whether good or bad mutation, is not to allow the virus to replicate. Therefore, give very potent, effective antiviral drugs. And effective, potent antiviral drug is what is not available for pediatric patients, as we're going to see, because all their drugs are suboptimal. And this is why you probably also see that the viral suppression rate in the pediatric patient is always lower. Yesterday, we are informed that we are now having suppression rate of 88%. That is fantastic. Suppression rate that we are familiar with when we are talking about HIV medicine is 50%, 47%, at the best end, 67%. That is the usual viral suppression rate. And you can see in this diagram here, the lower the age, the lower is the virological suppression rate. And when suppression rate is high, is low, it means you are having replication. It also implies you are mutating, the virus is mutating, and resistant mutation will be developing. In many countries, that UNICEF, as of all antiviral therapy, and when we this morning, I'm still here, or yesterday I was still here, we are still using a verapine as prophylaxis for our children. The drug that easily develops resistance most of all the antiviral regimen is nevirapine. It happens to be the anchor of antiviral drug for our patient. The AZT, our pediatricians will not use it. I don't know why they will not use it. They will say it's going to cause severe anemia in their babies. They will prefer to use AZT in the first month of life, but after the first month of life, what you will see is a back cover. They will never place our children on AZT. And a back cover has low resistance, but can spit it on your chest. And there's nothing you can do about that. Most caregivers may not even repeat it, and they don't even know what to do. These are the issues. And at a point in time, they develop, I think, the pellet. The pellet is such that the chemistry of the pellet, or the pharmacology of the pellet, is that it must not be broken. It must be hardened, and it's very cumbersome for the children to receive this. And atazinafar ritonavir, one important problem of atazinafar ritonavir that has benefited the adult, but is not very useful in the children, is the fact that it causes unconjugated hyperbilirubinemia. They say, we don't want jaundice for my baby because it can easily cross the blood-brain barrier. Lagos University Teaching Hospital in 2010, 2012, when we enrolled about 100, I'm showing that data on the slide there, you can project it there. A study that was done in Lut. High level of pre-treatment HIV drug resistance and treatment failure in Nigerian children. Go there and let them see. That study was done between 2010 and 2012 at the Lagos University Teaching Hospital, when 100 children were prospectively enrolled into treatment. And what we did, as you are enrolling, you are collecting your blood for drug resistance assay to note what proportion of the children already have drug-resistant mutations before we started them on antiretroviral therapy. This was what was done in 2010-2012. And what we found was that of the 90 that had sequence report, 13 of our children had drug-resistant mutations. That was 16% of our children. At the beginning of therapy, they already are compromised. The 13 children and the 69 children that did not have pre-treatment drug-resistant mutations were followed up for 24 months and see what proportion of those that had pre-treatment drug-resistant mutations as compared with those who didn't have pre-treatment drug-resistant mutations eventually develop what we call virological failure. Of the 13 that had initial pre-treatment drug mutations, 12 of them were still available for us to analyze at the end of 2 years. And 7 of them have developed viral load right there in treatment failure. And a fewer percentage of those that didn't have pre-treatment drug mutations also failed. But you can see that 54% or 55% of those that have pre-treatment drug-resistant mutations have failed. And there's hardly you are going to do for this individual. You are taking up to 2 years before you are now saying you are moving them to second-line regimen. Second-line regimen that is also not really very effective. This is why you have a lot of mortality, among our children. Now, after the experience at the Lagos University Teaching Hospital, we had another national experience. At this time, we collected, this thing is not moving, we collected samples. Yeah. This is the national effort. And this was done year 2016, 2017, and 2018 in Nigeria. Because what we did at that time was to implement WHO fourth criteria for drug resistance surveillance. That is, looking for resistance mutations among children aged less than 18 months. What we did was to move throughout the country, and we collected what we refer to as DBS samples that were archived in the sequencing laboratories. And about 540 DBS samples were collected. Of those 540 DBS samples, about 405 or 450 of them were evaluable, because we sequenced these viruses. The viruses that time we did not have in-country capacity for sequencing. Our samples were taken to Kisumu in Kenya. See this laboratory in Kisumu in Kenya. This is where the sequencing was done. What I realized was the fact that 48% of children in Nigeria that were born in Nigeria already had treatment failure or drug-resistant mutations, 48%. When we now dichotomize these 430 children that have sequence data for us into those whose mothers took antiretroviral therapy during gestation and those whose mothers didn't take antiretroviral therapy during gestation, we find out that those, about 205 of them, whose mother reported exposure to drugs during gestation, 57% of the children born to these mothers had drug-resistant mutations. Before you started them on therapy, they have already developed mutations. And about 34% of those whose mother reported not taking antiviral therapy during gestation also had mutation. So whether, don't worry, don't say, the mutation, for the mutation to occur is a normal, is a physical property of the virus. Virus will as long as the virus is replicating, mutation will occur. But drug-selected mutation is more likely to occur if you are exposed to a particular, and this is what we found in Nigeria, and we have actually documented this. Now, the good news is that these are experiences in the country in the past years. It's very unlikely that we are going to be recording these experiences moving forward. And why? The why is we now have a very useful agent that's able to overcome most important mechanism by which the HIV has to develop mutations. Because if the virus is not replicating, it's not going to mutate. Once it's replicating, it's going to mutate. Now we have this drug called dolutegravir, and I think nearly 95% of our children have been placed on dolutegravir-based regimen. The important property of dolutegravir is that it complexes usually irreversibly with the integrase enzyme. That's one thing about it. Number two, important property of dolutegravir is the fact that mutations that are selected for by integrase enzyme, most of these mutations does not stop dolutegravir from inhibiting the replication of the virus. This is what we have known. However, there are some mutations which has now been published. If you move and move, so that I can show them, which have now been shown to be capable of inhibiting, stopping dolutegravir from being able to inhibit HIV. And these mutations, number one, is this mutation that is called G118R mutation on the integrase gene. When that mutation occurs, the genotypic resistance score of dolutegravir is 60. Dolutegravir will not work. The other mutations that make dolutegravir not to be able to work is R263K. R263K will make dolutegravir to just be, make the virus to have what they call low-level resistance to dolutegravir. These are the two mutations that we know might actually become problematic. But one good thing here for dolutegravir is what we call additive mutation, which we expect to make the drug not to be useful again. But for dolutegravir, when there is additive mutation, it makes the virus to become sensitive again to dolutegravir again. And that's what you are going to see in the next slide here. You can see the 263K mutation. When it occurs, in less than a minute I will finish. Thank you. The R263 mutations, if you continue the patient that has R263 mutation on the same dolutegravir and acquires extra mutation, in particular, the H51Y mutation, the dolutegravir become very, very useful again, because the virus become 100% susceptible. And when you have E138A mutation occurring together with G118R mutation, then the dolutegravir becomes very, very useful again. So continuing an individual on dolutegravir who you have suspected may have failed to get dolutegravir, if you continue that individual on dolutegravir, you can see at a point in time, they can become biologically suppressed again. And this is what the advanced trial actually proved. The advanced trial was presented at IAS meeting in Melbourne in 2003 and 2023. This is where they presented this. You have 351 patients that were started initially on TAF, FTC, DTG. You have another 351 patients that were started on TDF, FTC, and DTG, and another group of patients started on TDF, FTC, and efavirenz. The baseline initial suppression was common in the three. However, following them up to 48 weeks, 96 weeks, and 192 weeks, what came up was the fact that nearly everybody, 95% of patients that were put on the dolutegravir, who started and who developed mutations, after 48 weeks, 92 weeks, 95% of them resuppressed. And the conclusion, therefore, from that study is that if an individual happens to show evidence of failure on DTG-based antiretroviral therapy, don't haste to switch to a second-line regimen. Go to the last slide, take-home points from this presentation. The take-home points on this presentation. Yeah. Let it come up. Well, it's not showing. The take-home point is that the children that unfortunately, our children before now had been exposed, had been disadvantaged with the potency and the quality of ARV that we have given to them. Number two take-home point is that the child is at the mercy of the mother. Once the mother is HIV infected and transmit the virus to the baby, the mother that infects the baby, that mother already has resistant mutation. That is a take-home point. And the last take-home point here is that we are happy DTG has come, and it's very unlikely that we'll begin to see a lot of treatment failure. And this will explain why treatment suppression rate among adults today, we are now hearing 93%, 95%. Among children, we are now hearing 88%, and which we think, if adherence is not a problem, you should get to 95% even for our children. However, it's important that we should still be able to document what Nigerian experience is with respect to evolution in the era of widespread use of DTG in Nigeria. I think CDC is in the hall. I hope WHO is in the hall. You should still support Nigeria so that we can document what's going on in the era of DTG use and HIV drug-resistant mutations. Thank you for your audience.
Yeah, please, let's appreciate Prof. Mo. Thank you for the professorial lecture. He actually took us through a journey from what resistance is to the magnitude of the problem in Nigeria, to the good news, down to the take-home message. I think, thank you, Prof, for agreeing to come to this symposium, and thank you for the lecture. Yes, we really appreciate you, sir. Let's go to the last speaker, in person of Dr. Peter. He's going to take us through HIV service integration, findings from monitoring, visiting to 18 states on HIV service integration in Nigeria. Please, let's appreciate him. You have 15 minutes to do so, sir. Thank you.
Okay. Good morning, everybody, once again. I think profs are taking us around on drug resistance. And you don't have an integrated site. If you don't integrate, I don't think we'll be able to achieve all that he has enumerated. So there's need for us to at least integrate and especially in this era of forcing funding. So this morning I'm going to have taken us through an overview of service integration. Also give a brief summary of the assessment that was conducted across 18 cities supported states about 2 months ago. Well, I think we are all aware of this. I think yesterday we are told about that we are Nigerians, we are more than 218 million. I think current estimate puts about almost 235 million people. But I think the NMPC of 2022 put the population at 218 million, and our current prevalence from 2018 NIA survey put us at 1.3%. And approximately we have 2 million people PHIV, that are affected, and currently about 1.76 million are currently on receiving ARV drugs. And we have over 34,000 health facilities across the country, and these are distributed about 88% of them being PSC, 11.7% on secondary facilities, while 0.3% are tertiary facilities. And it's interesting to know that we have over 200 health facilities across that provide comprehensive health services in country. Next slide. So, you can bear with me that people, PHIV, they are called recipients of fear. They are not only burdened by only stigmatization and discrimination, but they have other health challenges that are burdening them. So most of them are faced also with mental health issues, non-communicable disease, mostly diabetes and hypertension. And for us to properly integrate, take care of them, integrate services so that it can be able, because we are talking about the same person being affected. So HIV service integration has emerged as a strategic approach that combines prevention, testing and treatment support services into a comprehensive and connected package. What it means that instead of having disjointed services, we have to integrate so that the same individual have a comprehensive package of care in these limited resource settings, in the country. So by delivering service in a manner, this model reduces barriers to care, enhances access, and promotes a more holistic and person-centered health service system. The goal of the HIV service integration is going to create a seamless, sustainable healthcare system, that meets the diverse needs of recipients of care and communities, while improving the quality of continuity of care for them. At least, we are confident with what happened about early this year. We have had post-and funding. A few years ago, we didn't anticipate this, but we started this issue of service integration and sustainability so that you can be able to overcome this, when things like this happen, be able to overcome it. So that's why there's need for us to properly start this service integration across facilities so that we can maybe self-sufficient and improve our healthcare delivery system. Next slide. So in country, we have two basic models of service integration that are being practiced, in country. We have the full integration, whereby the HIV service is being embedded within the general healthcare system. That by limiting standalone health clinics. The same healthcare provider provide both HIV services and non-HIV services. That by enabling a holistic and person-centered approach and better resource use. And this is the kind of model that we've seen in most of our PSCs and some of our general hospitals. But the second one, partial integration, whereby the partial integration model is deliver health care through a dedicated team of, especially who are collocated within the health and our tertiary facilities, where there are so many professionals, and consultants. The HIV service and referral, we also current or referral of patients internally to the expert teams, what means that for some of these patients that have other, services, they are being referred to specialists where they are being properly taken care of. And this is what we found out in most of our tertiary facilities and also federal medical centers and specialty hospitals. Next slide. So for us to properly, implement this HIV integration, we have a constitutional framework, which was built on at least the 6 building blocks of WHO building blocks of sustainability. So we have the procurement determinants, the moderators, and also the opportunity for and challenges. So I'm on board with this. Next slide. So for us to properly implement this integration, how do we coordinate? Because if there's no proper coordination, we won't be able to implement effectively. So the coordination is carried across the 3 levels of 3 levels in the country, both the national, the state, and also the health facility. At the national level, NASCP coordinates the strategic implementation of HIV services. Thank you. So at the national level, NASCP coordinates effective implementation of these services across health facilities, working collaboratively with sister agencies, leveraging on technical input from our service integration core group, drawn from our task team members from the academic institution, as well as our implementing partners. And what they do that they help in providing oversight functions across. Okay, thank you. So at the state level, the connection is being done to the state level, to the state Ministry of Health, and we support directly implementation of this health service integration for the facilities. While at the facility we have mostly our ARD coordinators and also facility heads who coordinate implementation at the facility across all the facilities. Next slide. So in planning for this service integration, we put out a series of activities, to ensure effective implementation. First of all, we constituted and inaugurated the service integration core group, made up of members from the national task team and other academy and also IPs. What they do is that they provide oversight function in coordinating the service integration at the national level. We also have carried out needs assessment, across all the facilities, to assess gap analysis to ascertain a level of full implementation. We also paid our voice to some key stakeholders in the state. I'm sure most of our commissioner and the SAPCs were able to at least host some of the team that came to the state to advocate for this implementation of service integration across the state. We also developed training material, service integration document that will help us full implementation of this across all the states. We have also been able to build capacity of some healthcare workers, especially our clinical mentors, who will serve as to start on the training across the facilities in the state. With support from ICAP, we're able to carry out the baseline assessment in 4 more states, which were done earlier this year. We are able to engage other sister agencies, MPSDA, and other family health, so that we can properly integrate across all the disease entities. Next slide. To be able to properly monitor what's happening, we are able to develop data collection tools which are reviewed and harmonized so that it can help us for a seamless data reporting across all the levels of care. The service integration core group meets from time to time to review the findings from this assessment and also provides recommendations to improve the implementation. So, however, we are faced with some daunting challenges in implementing in carrying out this implementation. Next slide. Next slide. So, we are faced with some challenges when the process of carrying out this integration across facilities. One of them is for the resistance within the healthcare facilities and also state level leadership. We also have the fragmented electronic system. The recipients of care have a different electronic medical record system, different from what's happening at the other health facilities. So we also have inconsistent political will, fluctuating commitment, which continue to impact on program momentum. Of course, competing priorities, which trend system as far as resources divided among numerous diseases. We also have a complex and evolving HIV program landscape. We demand continual adaptation at all levels. Of course, limited service implementation in rural areas. So these are some of the key challenges that we face in terms of implementing this. Next slide. So some of our key enablers for integration, we have to be able to targeted advocacy to major stakeholders, which are also strengthening support for seamless implementation. I'm sure most of us, most of the SAPC commissioner will be able to, host people that came for advocacy visit. We also be able to designate senior facility staff to champion and drive integration effort at the facility level. And also our continual quality improvement effort being actually implemented across those various facilities to be able to identify barriers and develop means of overcoming them. And also to residents of care being advocated to that they should be included in national health insurance and said health insurance team to can be also promote sustainability for them. Next slide. On the part of our various electronic medical systems, we are proposing that they should be harmonized so that we have integrated data reporting across all systems. Also, build capacity of our healthcare workers, to be able to effectively carry out this. Next slide. So I will go into the main, go to next slide, the findings from these facilities where we carried out this service integration across the 18 states. Some of the findings. Go next slide. Next slide. So yeah, so this across the 18 states where we visited, about 91 facilities we are assessed, and most of states experience it was doing this we having 4% funding. Most of states experienced a disruption in services due to pause in funding, and that affected what happened across all the facilities. And the findings were cut across all the states. We are similar across all the states. So what we found out was at least there was full integration of some of the services we states, especially PSCs, where they are full integration, but some levels of partial integration is observed in most tertiary and secondary facilities in the states. Ad hoc staff, we also found that ad hoc staff are responsible for most of data entry and management, most of the facilities visited in the states. Most IPs employ ad hoc staff who carry most of the data entry and management across the facilities. Training of HIV service integration have not been conducted for most of the facilities visited across the states. Except Nasarawa State, where some training have been conducted for some of the health facility staffs. Next slide. We also observed there was human resource availability gap in most of the facilities visited. Although efforts have been made by the River State governments, who have been able to recruit some health personnel who have been posted to some of the secondary facilities. And also, we also observed inadequate ARVs, test kits, and other essential HIV commodities. We are also identified. Logistic management for laboratory samples was also a very big challenge in most of the facilities visited. Also, loss of capacity building for facility-based MIE officer was also observed. Tax shifting and sharing already operational across some of the facilities visited, but in varying degrees. Next slide. National state government have been able to convert most of their casual staff to full-time employees. I think I appreciate them. They have been able to, this is what we are advocating, and this was what yesterday, one of my directors who advocated, I think Prof, that most of these ad hoc staff should be employed. I think national states have been able to key into this. And also we access to client folders and electronic tools. We also restricted, especially during the stop order in some facilities. It was also observed no service integration across most of the facilities visited, especially in some facilities in Plateau states, Kogi, on those states, some of those facilities, no service, no form of service. So we are there's need for improved data management slides. So our key next steps now, which is more why we are convening this meeting today is for us to, first of all, we are going to need to disseminate some of the service integration manual and SOPs that we have been developed to the states so that they be used at the states. We will need to organize stakeholders and meeting with state commissioners of health, director of public health, CMDs of teacher facilities to discuss the modalities and benefits of HIV screening, because it was about doing our assessment that most of them don't even have the full concept, the full grasp of this. So we need to advocate for them for more sensitization visits so that they can be able to, key into the idea that service integration is the way to go. Also, data management tools, MIE tools, we are fragmented, so are not sufficient to foster health service integration. So there's need for us to unify and harmonize data management tools